Good afternoon and welcome to our Neuroscience lecture series. My name is Dr. Rogelio Rivas. I'm happy to be with you today. During this interactive presentation, you will have the ability to ask questions via the chat box on your screen. Please post your questions directly to the moderator. This afternoon, I have the pleasure of introducing Dr. Felipe De Los Rios. His presentation will be on stroke, the silent pandemic. Dr. De Los Rios is a board-certified neurologist and vascular neurologist at the Miami Neuroscience Institute. He is the medical director of the Comprehensive Stroke Center at Baptist Hospital of Miami, part of the Miami Neuroscience Institute. Dr. De Los Rios received his medical training at the Universidad Peruana Cayetano, Heredia in Lima, Peru. He completed an internship in internal medicine, followed by a residency in adult neurology, both at the University of Cincinnati University Hospital in Cincinnati, Ohio, where he also pursued a neurovascular fellowship. In addition to his work as part of Baptist Health South Florida, Dr. De Los Rios serves as a volunteer associate professor of neurology at the University of Cincinnati College of Medicine in Cincinnati, Ohio. Dr. De Los Rios has published extensively in his field of specialty. He has participated in over a dozen research protocols and has been a speaker in numerous conferences in the United States and abroad. He is a member of several professional societies, including the American Academy of Neurology and the American Stroke Association. Dr. De Los Rios is fluent in both English and Spanish. Please let's give a warm welcome to Dr. De Los Rios. Doctor?
Thank you, Dr. Rivas, for that kind introduction and for inviting me to speak about this important topic. Let me share my screen here. All right. So that you're able to see my presentation correctly? Is that so?
That's correct. We're good.
Excellent. Excellent. All right. So I have no disclosures. Make sure here. Yeah, no disclosures. And we're going to go over a little bit about what the burden of cerebrovascular diseases is for our region, and explain some of the common challenges that I have found that have been reported regarding stroke care at these locations. And it's not the same thing for everyone, so it's a little heterogeneous, but you at the end might be able to maybe share some of what you've noticed in your own countries, and at least formulate what we have been targeting as a path forward to help some of these locations develop their stroke resources locally. So stroke is a world health problem. In the US in particular, let's say it's the number 5 cause of death in the US. It accounted for 1 of every 19 deaths. There are more than 7 million stroke survivors, right? One thing is dying from something. We're all going to die from something, but another one is surviving with disability. By 2030, an additional 3.4 million adults, that's 3.9% of the adult population, will have had a stroke. And that's a 20.5 increase in prevalence from 2012. When we talk about world statistics, this is for 2017, stroke continues to be the 2nd leading cause of death and the 2nd leading cause of DALYs. And DALYs stands for Disability Adjusted Life Years. And I'll talk a little bit more about that after. There's about 12 million incident, 104 million prevalent, 6 million fatal, and 132 million stroke-related disability adjusted life years lost due to stroke. Now, even though the stroke incidence, prevalence, and mortality in DALYs seems to have declined somewhat from 1990 to 2017, the absolute number of people has increased dramatically, in part because of population changes. So if you can say in a very simple message how common stroke is, 1 in 6 people will have a stroke throughout their life. So we all know or have heard of someone who has been touched by this condition. When we talk about women specifically, 1 out of every 5 women will have a stroke sometime in their lifetime. So very common condition. Now, the bulk of stroke burden happens in low to middle income countries. So 80% of all incident strokes, 77% of all stroke survivors, 87% of all deaths, and 89% of all stroke-related DALYs happen in low to middle income countries. Before, we used to think stroke is a disease of richer countries. That's not quite so. It does seem that ischemic stroke might be a little bit less common in low to middle income countries at 65%. Generally, that number is about 80%. And we see a little bit more representation of intracranial hemorrhages and subarachnoid hemorrhages. Normally, subarachnoid hemorrhage is somewhere between 3 and 5%, and it has been reported to be about 9% in low to middle income countries, and intracerebral hemorrhage is usually about 10–15%. And there might be quite a bit of bias as to who goes to the hospital to seek care, what the access to imaging is, and I'll go into more details later. So the numbers might not be too different between high income and low to middle income countries. It's just hard to say for sure because of lack of information and somewhat of a referral and testing bias. So going a little bit into more detail regarding DALYs. Again, this stands for disability adjusted life years. And you can think of one DALY as one lost year of healthy life. And when you sum all of those across the population, you can get a measurement of the burden of disease and what's the gap between a current health status and an ideal health situation. Where the entire population lives to advanced age free of disease and disability. So DALYs equals years of life lost plus years of loss due to disability. And you can calculate years of life lost and years lost due to disability with the formula like you can see there below. And when we talk about low and middle income countries, we're referring back to the World Bank classification. I mean, basically you have high, upper middle, lower middle, and low based on the gross national income per capita in US dollars. And then that's calculated using the Atlas method. And this is updated every July. The country classification is determined by two factors: the gross national income per capita, and that can change by the factors listed there: inflation, economic growth, etc. And then classification threshold, and that is adjusted for inflation annually using a specific formula listed there. The Atlas method smooths exchange rates fluctuation using a 3-year moving average. And if you are good at math, you might want to try a stab at that, but if not, you can just take it from the online source. And when we look at what are the thresholds for 2019, July 2019, July 2018, you can get a sense of what is the income, gross national income per capita as to what defines a lower middle, upper middle, and high income country. Now, bear in mind what Alteplase can cost. So Alteplase, which is the only FDA-approved medication to treat ischemic stroke, a vial, a 50 milligram vial in some countries, can cost upwards of $7,000. So you can see how that can be very prohibitive or a challenge in low middle income countries. I mean, that's more than or double, maybe sometimes more than what many people make a year. In the US, for 2014, a 100 milligram vial, which is usually what we use most of the time, was costing about $6,400. So the price can vary, and it actually has been going up rather than going down throughout the years, at least for the US. So which countries are we thinking of when we talk to lower middle, upper middle, and whatnot? So here you can see a list of low income countries, lower middle income countries with a range at the top, upper middle income countries, and then high income economies. And I'm just gonna highlight just a few here because I have a little bit of experience with some of these. So I wanted to talk a little more about those later. So that's the Dominican Republic, Peru, which are considered upper middle income countries, and then Panama, which is considered a high income country. So when we talk about world population, this is the GDP per capita. You can see most of the world is not a high income country, or more in the low and middle income country categories. But if you adjust the map based on population, this is what you get. So this is based on population, and you can see the areas where our more populous countries have been inflated. So it's not just the territory, but it's who lives on those territories. So globally, from 1990 to 2017, there has been a 76% increase in the number of people with new strokes, stroke survivors, stroke-related deaths, and DALYs. And again, part of that is based on world population changes. So in 1990, there were 5.2 billion people, and in 2017, that number had a 42.4% increase. And not only is the number of people, of course, that have increased, but also the life expectancy, which is a good thing, of course. From 64, it have increased to 72. But that will mean that we have a significant increase on diseases that are associated with aging. That includes, of course, dementia and heart attack, but it also includes a lot of stroke. Stroke increases as we age, especially after age 50 or 60, but it's not a disease that is exclusively of older age. About 10% or so of strokes can happen on people that are younger than 50. And of course, when it happens in this age population, the disability that it accrues is quite significant. It affects people and when they're quite productive in their lives. For high-income countries and low to middle-income countries, the trends are a little bit different. So for high-income countries, people aged 15 to 49, so we're talking about young adults, there is a 6% increase in stroke incidence rate without significant change in stroke prevalence. And there has been some reductions, significant reductions in stroke mortality and DALY rates. So we are seeing more strokes, but thankfully, due to advances in therapy, we're seeing a less disability associated with them. In low to middle income countries, there's been a 4% increase in stroke among young adults. And there has been some declines in stroke incidence, mortality, and DALY rates as well, although not as dramatically as we have seen in high income countries. When we look at the trends, and this is based on age, so you can see, for example, at the beginning, the top row here, let me see if I can get my mouse to work. Okay, here. So you can see this first group here, there's the different age cutoffs. So as you go up, the age is going up. The top number is 80 plus, and then the bottom ones are 15 to 19, 20 to 24, and so forth. And you can see as the years have been going by, how the incidence has been changing, most notably for older women. And that's in part because women tend to live longer than men do. Deaths and DALYs, as time has gone by, you can see how those have changed over time from 1990 to 2010 and beyond. And you can also see that there is a significant impact on young adults as well, not just on those that are over 60 or so. So definitely when we're talking about stroke, we should focus on stroke prevention. And stroke prevention is really where, when we're talking about public health, it makes the most sense. It not only prevents stroke, it prevents all forms of cardiovascular disease. And acute stroke is very, very expensive. Like I mentioned earlier, just the medication can be many times what people make a year. But prevention is sometimes hard to do. It requires a lot of effort and follow through over time. And even though it helps, it doesn't prevent all of strokes, of course. Even though we consider that about 80% of all stroke is preventable, there are going to be people still that have stroke, and we should have a system in place to treat them because we have effective therapies now. So out of 1.3 billion people in 104 developing low to middle income countries, accounts for 74% of the population live in multidimensional poverty. And when we talk about multidimensional poverty, you can see below what that means. So for health, there's a nutrition indicator. For example, an adult under 70 years of age or a child is undernourished, child mortality, years of schooling, if you have basic sanitation, cooking food, drinking water, and electricity. So you have 74% of the world population living in multidimensional poverty. And it's very hard to do long-term secondary prevention and even acute stroke care, obviously, when you have that sort of situation. When we look to access to imaging, right, we're saying that in low to middle income countries, there's a higher incidence of intracerebral hemorrhage and subarachnoid hemorrhage and a little bit less of ischemic stroke. That really depends a lot on your imaging. So ischemic strokes tend to be a little bit less severe, and many people don't go to the hospital unless they're having severe, very severe symptoms. ICH, subarachnoid hemorrhage, produce severe symptoms much more often. And we're talking about CTs and MRIs. It's really hard when you have very difficult or just spotty access to X-rays, for example. Here you can see one hospital in Boston has 126 radiologists. The country of Liberia had 2 at that time. And there's some data on this as far as CT availability per million population. You can see that for many countries, there's not that many CTs per million, sometimes under 1. And that's even worse for MRI. An MRI really does a much better job at picking up, for example, acute ischemic stroke. And if you don't have access to MRI, your reporting of ischemic stroke is going to be affected by that for sure. And there's many countries that has much less than 1 MRI machine per million population. Neurologists too. There's a shortage of neurologists, not only in the US, but across the world. So neurology training is available in 59% of countries. Population per neurologist can go up to even 4 million per neurologist. Many of them are working in private practice in larger cities, which also makes an unequal distribution of the service, which is really the neurologist is the one that drives stroke care in most of the locations. However, when we're speaking about specifically acute stroke care, for example, because of this shortage of neurologists, many times we rely on the expertise of other providers. So emergency room physicians, intensivists, for example, can definitely pick up and help, but training is required for sure. Many neurologists don't have specific training in stroke. There's no stroke fellowship trainings in many countries that have neurology training as such. So that also adds to that shortage. So why are we speaking about acute stroke treatment when the numbers are so challenging? And the truth is, and I'm sure many of you can relate to this, it's an unequal picture. So in a city, you can have extremes of poverty, and you can also have significant areas of population that live, in relative luxury or in full luxury, it's going to be hard to do something that benefits everyone at the same time. And usually what happens with these sorts of interventions is you have to start somewhere. You start somewhere and then that gets expanded to cover as most people as you can. But you have to establish that basis, and taking those first steps are definitely initial challenges. So when you look at that, as far as what percentage of the population within each country has upper middle income, and you can see some data there. Specifically if we talk about, for example, Peru, you can say that appears to be between 10 and 20%. Mexico, similar numbers. and so forth. So it's unequal, and there's definitely opportunities for some of these more resource-intensive therapies to be available and help a significant amount of the population. When you talk about high income, of course, that's a little lower, as you can see there. So I just want to share a little bit about what my experience has been working in some of these locations, and then get your thoughts on it, as well as what it has been your experience at your particular country or program. So I'm going to talk a little bit about Peru. I'm from Peru, and I've worked in Peru as a neurologist, and I have close collaboration with quite a number of physicians back in my home country. So if we talk about Lima, Lima has a population of about 10 million. That was in 2017. It's one of the largest metro areas in the Americas. And it's not only the people that live there all the time, but then you also have this floating population that comes and visits, many of which are elderly individuals as well. And the healthcare model is decentralized. So the Ministry of Health is about 44%, covers about 44% of the market. Those are people that are not benefited from Social Security, which goes through Salud, which covers about 25%. And then others are, for example, armed forces, the private sector, police, and they have their own systems for health. So it's not easy to jump from the hospital of Salud to the hospital of, for example, the armed forces. You couldn't do that. So there's a little bit of somewhat siloed approach to healthcare, and the resources have to be developed almost in parallel at each one of these systems. And when you look at Peru, as would be expected, at least on that 10-year difference from 2007 to 2017, stroke is on the top 5, third in 2007, fourth in 2017. You still have a lot of people dying from respiratory infections, so that's still number 1. But stroke and heart disease, which are tied together at the hip, are quite at the top. So non-communicable diseases are the leading cause of death in this location. And 75% are insured. Altiplace TPA is covered by public and private insurance company, but there really isn't any stroke system of care as such. There are no certified stroke centers. If you had a stroke, you would have to kind of guess which hospital you would want to go to. The emergency system wouldn't know necessarily which hospital it is. Not all hospitals have neurology access. Not all hospitals have access to Altiplace or an endovascular surgeon that can do a thrombectomy and remove a clot from a blocked artery. There are multiple non-coordinated private and public voluntary, I should say, emergency response agencies, and you cannot get a stroke fellowship program. You can train in neurology, but there's no stroke fellowship program as such. And there are a few centers that can provide endovascular surgery to stroke patients, maybe not 24/7, but most days. However, the average person wouldn't know where to go. EMS would certainly not know where to take you. So the vast majority of neurologists would not feel comfortable using Altiplace or have not used it ever before. They would be worried about selecting the patient appropriately or managing the complications associated with it. And the hospitals generally don't have stroke-specific pathways as such. There's a burden on the physician, on the neurologist who is taking care of the stroke cases, because there's really no additional reimbursement for any type of time that the physician is spent caring for a stroke patient in the emergency room outside of just the standard basic evaluation. So there's no incentives to really develop this from a clinician side. And the neurologists are generally trying to stay out of the emergency room and focus on their outpatient visits as well. So it's not like people are necessarily jumping to tackle this issue. And most centers don't use telemedicine, at least not in the emergency room situation. And there's a large gap between the number of providers. It's not easy to go from one place to the other. And there are gaps for the care of the stroke patients because of that. And telemedicine is making its headway more and more, but there's still a significant gap and opportunity to be taken. So when I was there specifically, stroke was not considered a profitable enterprise by administration in general. Hospitals and insurance companies did not spend much money on nursing home care. There's really not much of that or inpatient rehabilitation. So the patients, once they leave the hospital, they essentially go home and are cared for family members and do outpatient therapy. So there's when you talk about downstream savings with higher upfront costs to the insurance companies, they're like, you know, we don't really spend much money on this. So we spend some time, I spent some time doing acute stroke treatment awareness, developing protocols, educational materials, developing partnerships, and establishing the foundations for some stroke programs to develop. And this is, for example, one of those with Hospital Nacional Cayetano Heredia, which is where I trained. And that's a hospital within the MINSA pathway or system, I should say. The hospital CT scan is not owned by the hospital. It's owned by a third party. So that adds additional challenges because you can't just necessarily take a patient straight to CT from the emergency room, because the owner of the CT machine may say, hey, you might not be paying me for this. So there's some more limitations on what you can or cannot do. But that's, you know, the reality of it. Endovascular treatment was not available last year, but my understanding is that they now have someone who can provide endovascular surgery sometime, not 24/7, but some periods of time. And the hospital has about 367 beds, 58 ER beds, which are always full, 94 outpatient offices, more than 6,000 visits per month in the ED, and about 1,400 discharges per month. And that's me and some of the physicians that came from Hospital Cayetano to visit the program here in Miami. And the program launched in July of 2018. And just so that you get an idea, from 2016 to July of 2018, there were very, very rare TPA treated patients. They did not particularly do well. They had 2 hemorrhagic transformation and deaths, so 50%, which is a very large number. And that probably just goes back to selection of who is a candidate and who isn't a candidate for this type of intervention. And starting in July of 2018, and this is data from the first months of 2020, you can see the number of stroke patients that they saw. They had 32 TPA treats last year, and they had 4 the first few months of 2020. I just don't have the data for the rest of 2020, but it gives you a good idea of the amount of treats that they did in 2019. And it's not that the patients were not there in 2017 or 2016 or 2015 and so forth. They just didn't have the setup at that time to provide this treatment. Time is very important for stroke care, of course, and that's something that mature programs are working on continuously to provide good optimal door-to-needle treatment times. And they started at 76 minutes, and then they went down to 68, and then they went down to 59, and they'll continue to do better as they get more expertise and they consolidate their protocols. But that's a fantastic change for them over just a couple of years on the number of people they are treating with acute stroke and changing their outcome and functional disability. I'm going to switch gears here a little bit and talk a little bit about Dominican Republic. For the Dominican Republic, stroke is a very common cause of death. So it's second in 2017, and it was second in 2017, just below ischemic heart disease, again, non-communicable diseases. And population about 127,000. However, about 6 million people traveled there in 2017. So you can see the amount of floating population that comes to the country. And they have a social security-based healthcare model, Servicio Nacional de Salud, and family health insurance is offered to about 65.3% of the population, and they have 3 subdivisions: subsidized, contributory, and contributory subsidized, as you can see there. And Alteplase is covered by public and private insurance company. However, there really isn't much in the sense of stroke systems of care either, just like in Peru. You can't get really a certification as such locally. It's not something that hospitals currently have. There's also multiple non-coordinated private and voluntary EMS agencies. At least at this particular facility, there were 2 neurologists. I'm just talking about a particular facility, not for the country, 2 neurologists. Also, you can't get fellowship trained in the country. There's no fellowship program as such. There's no neuroendovascular surgery program either. And telemedicine is not really a mainstream either just yet. Most hospitals don't necessarily have stroke care pathways. And similarly, there's no additional payments for stroke alert cases that are time intensive, are more critical patients, are higher risk of complications, and demand more time from all clinical staff and from the hospital as such. So again, not much support for this group of patients that require time and commitment and a lot of coordination. And we have established a program to help a facility develop their stroke leadership structure, care pathway, protocols, order sets, provided education to emergency room physician, intensivist, radiologists, ICU nurses, some minimal acquisition of technology because they really had most of the things that you would need to do things for acute stroke care. And transfer algorithms so that there's no wasted time for patients that could benefit from endovascular surgery, and then also some ongoing stroke case education. And those are some pictures of us and the interventions that we did there. That program is ongoing. We've had some delays this year because of coronavirus, unfortunately. But we're very eager to jump back and be able to share with you at a later time point the results of this intervention for them. But as you can see, some of the common challenges already there between, for example, the Dominican Republic and Peru. And lastly, I want to talk a little bit about Panama. This is in Ciudad de Panama, which is the capital city. You can see the population there. Again, lots of visitors. Almost 2 million that year. They also have a decentralized healthcare model. So Ministry of Health is 47%, Social Security system, 84.4%. And then there's a smaller group of private as well. And for Panama, stroke is also a leading cause of death in 2007 and the same in 2017. So very similar to the Dominican Republic. And yes, 100% are insured in some way, shape, or form. Alteplase is covered by both public and private insurance company, but there really isn't a stroke systems of care as such, right? So, for example, if you have a stroke within Miami, I'm just going to use that as an example, EMS has to take you to a stroke certified center. They can't take you by law to a hospital that cannot provide care for you. So something like that is not really set up. There's no certified stroke centers as such, either locally or internationally. And similarly, there's multiple non-coordinated private and voluntary EMS agencies. There is a dearth of neurologists. There's not that many neurologists, 12 for the country, but only Panamanians can practice medicine. So that's some of the challenges of them just getting more neurologists into the country to see patients. There's no stroke fellowship program. And there's no accredited neuroendovascular fellowship program either. There are neuroendovascular surgeons and they've trained in different places, but you just cannot get accredited training as such. And telemedicine was not in routine clinical practice, but we've been working hard to change that. Most hospitals don't have a functioning stroke pathways. There's no necessarily additional payments for stroke alerts for the hospital or the practitioners involved. And the neurologists, again, are very busy. They have very busy outpatient practices. They don't necessarily want to be spending a lot of time going to the emergency room and caring for acute stroke patients because they're very busy. Here we prepared for international certification. We talked about stroke leadership structure, care pathway protocols, order sets. We provided educational intervention to EDPs, intensivists, radiologists, and developed a stroke nurse program. So here the intensivists and the emergency room physicians really took up the challenge, and they were motivated to help stroke victims recover better and take on the stroke program. So the role of the neurologist was really taken over by this group of providers. There was a little bit of technology needs, but very minimal, really. The hospital had lots of resources already for this. And we developed a pre-hospital outreach program and ongoing stroke education as well. And those are some of the things that we did at the site. And this is some acute stroke treatment volume from 2018 to 2020, and just the first few months of 2020. So you can see the TPA really, increased its use by 300% or so, and that keeps on growing. And will continue to grow because there's lots of stroke victims in the country, and there's a lot of need. People just need to know where to go, and it has to be accessible to them. But this is the type of things, the interventions that you see can come out of an educational full 360 program. The door-to-needle times, really good. I mean, there's months where the door-to-needle time was less than 20 minutes, which is just fantastic. And on average, quite under 60 minutes, which is really good as well. So just to summarize a little bit, some of the common challenges that we see is that there's lack of support, both administrative, but then also there's physician challenges for stroke care, specifically acute stroke care. There's a need from a community health standpoint for stroke systems of care. Hospitals should be flagged. People should know which are the hospitals that are able to provide care for stroke victims, and those facilities should be fostered. They should be, the community should help those facilities succeed in developing stroke care resources for their community, and patients should go to those sites, whether they're public, private, or a combination of those, so that the expertise can be developed. And centers that do this regularly do this well. So you don't want to have 10 stroke centers that see 2 patients, every couple of weeks. You want to have 2 stroke centers that are able to feed a significant area of the population that do this on a regular basis. But you need financial support for this, especially for the non-procedural aspects of stroke care. Now, endovascular surgery has really taken off over the last 5 years or so. So we do programs like ours here in Miami are now doing almost as much endovascular surgery as we do alteplase medication treatment for stroke. So we had 113 endovascular treatments last year, and about the same number of IV alteplase treatments just in this one hospital. So it's about 50-50. And endovascular surgery is able to provide more financial support to many programs. So it makes them more sustainable over time, but you still need support for the non-endovascular piece of the program. Many hospitals need help with developing their stroke program structure, their infrastructure, their leadership. How do you coordinate service? How are you going to access endovascular treatment? And who would you spend those resources in? Who is a good candidate for endovascular? Who should go from which site to which site? Do we need MR or CT perfusion? Should we do it in all cases? On some cases, what is the protocol? Those are all things that we can help with as well, but those are things that need to be developed at each site. There's too few neurologists, just not just in low to middle income countries. There's too few neurologists in the US, and many have an outpatient focus. So how do you overcome that? Do you use telemedicine? Do you outsource? Do you rely on a group of providers such as EDPs or intensivists that are interested in learning more and taking ownership of stroke care? You need to provide education regarding management of the acute stroke patient, but also of the complications that may happen. And it's not just a physician thing. A physician alone can't do all this, of course. It's a team thing. You need good nurses that know what to look for. You need support from pharmacy, you need support from lab, you need support from administration, and so forth. This cannot just be something that a physician is tasked with, of course. and nursing training and public awareness and outreach. So we would love to say that we have made great success with public awareness campaigns in the U.S., but that's not necessarily true. The truth of the matter is that we have not been able to get a lot of stroke information to the general public, despite all efforts. That doesn't mean that we should stop. That means that we should probably try to target public awareness at a younger age, maybe school or younger individuals that can then teach their parents and absorb this information better as we grow older, right? We have done a great job at people recognizing heart attack from all sorts of different angles, be it the movies or just general knowledge. But people really need to understand stroke more, especially now that we have therapies that are effective when given in a timely fashion. And people should demand access to acute stroke care. It's a very common condition, very disabling, and we have treatment for it. So I guess this is just my last few slides on lessons and opportunities. And resources that we spend on stroke prevention are definitely resources well spent. However, we should not neglect caring for those that are currently having a stroke. And there will be a large group of people that will have a stroke, no matter how good our stroke prevention program is. And we should be able to care for them. There's plenty we can do to help communities in low to middle income countries and even high income countries get access to acute stroke care. And we can help bridge that training gap, just as our facility, but also other facilities throughout the world can help bridge that training gap. And expertise from one center can be passed to other local centers. You need one site to be having a great success stories, and other sites will say, well, I want to do that too. And then you don't have one site, then you have 2, 3 sites. And that's what happens here. You know, here in Miami, we have a population of about 2 million or so, and we have about 6 comprehensive stroke centers, another 6 or 7 primary stroke centers, and we're all very busy. It's a common condition. So I think a little bit of healthy competition is good. You can't have too many stroke resources in my book. And national programs should really support stroke care as well. You need national stroke care algorithms. You need the infrastructure, but also the ability to certify the stroke centers of excellence and help them grow and be sustainable. This likely requires public-private partnerships. You can't have a stroke program just for the police, a stroke program just for the military, a stroke program just for social security. You need to be able to partner and use those resources the best way you can. Stroke training programs are needed, and participation of stroke research drives interest and build on those stroke training programs. And we can help with all of that. So this is just to show, you know, some of the initiatives that we've been launching and are hoping to see grow into the future, trying to really help get education regarding stroke to physicians that are practicing in Latin America. And as we get more funds and this program grows, we'll let the international department know for people that are interested in participating. This is what I was showing you. This is a map of what I was telling you verbally, a map of the comprehensive stroke centers and primary stroke centers in our area in Miami-Dade County, with a population of about 2 million. You know, we can definitely make a difference out there. So I'm looking forward to hearing your comments, see what your experience has been in your countries, and any questions that you may have. And that's the end. Thank you very much.
Rios, what an excellent presentation. You left us all pondering on some of the statistics that you shared with us. And to start the discussion, I would like to point out 2 of the things that jumped to me immediately. And it's the fact that you mentioned that 3.9 million adults would have suffered stroke. And then the other component, especially dear to me, it's from the global health perspective, it's that 132.1 million stroke victims are going to be related to disability adjusted life years. That in itself constitutes a major burden on any economy. not counting with the other communicable diseases or non-communicable diseases that are also burden on certain countries. So you mentioned incredible lists, a list of incredible opportunities that these emerging economies can actually institute in order to start preventing stroke. So there is a lot of work to do, and this is exactly the type of work we need, which is communication, sharing of our expertise, bring experts such as yourself, as you have done for Baptist International in Dominican Republic and in Panama. Let's go ahead and open for discussion. And I know Dr. Rivas has a comment to make.
Thank you, Dr. Hakim. It's Dr. De Los Rios. I know that, you know, what we're trying to say is obviously not so much that if something is not available, but it means that one thing is better from the other, but it's the challenge, right? How do we challenge leaders to get this done? And we talk about, you know, COVID and telemedicine and, you know, all the changes that COVID has made us all go through. I think it's been globally for telemedicine. And so, do you think this has gotten better? Is this actually something that can help us now? And then, and moving forward, you know, the difficulty of treating stroke during these COVID times, but most importantly, the effect of telemedicine has had with you in the stroke treatment. If you can expand on that.
Yeah, I mean, and I saw in the chat there's a question from Murray Williams about that too, and thank you everyone for your comments there. And yeah, I mean, it's an underutilized resource. There's no doubt. And this COVID crisis has highlighted the opportunities that we have to use this technology in a much more productive and efficient way. Now, telestroke has use of telemedicine for stroke, which we call telestroke, has been around for well over a decade. And we use it every day here at the Baptist Hospital of Miami, which is a comprehensive stroke center with lots of resources, right? So that just highlights the opportunities that you have to build this into your program. And the reason for it is we don't want patients waiting and getting delayed care and getting more brain injury because a physician is just not in-house or outside on their home. And it's very hard to have in-house neurologists 24/7, especially if you don't have a neurology residency program, right? So we want to bring that expertise to the bedside. And we know that when you have a program that sees patients regularly, when you have physicians that see stroke patients regularly, you get more people treated. So people feel more comfortable and they select patients better, and more people get treatment. So we want to support that. And with having a basic platform, and you don't have to be very fancy with your telemedicine system. You do have to be compliant with your regulations regarding protection of communications, but there's many platforms, many software companies now that will allow you to have HIPAA compliant healthcare communication. And you can be as simple as, you know, an iPad on a stand and some wheels and making sure that it's charged in a process to care for the equipment and training on how to use it. And the physician can do standardized evaluations of a stroke patient over that video platform to determine if someone is a candidate or not for intervention. You do have to be able to put orders remotely, of course, because, you know, we can't just speak orders, we need to put them as well. So so you have to be able to access records and put orders, and so it's not necessarily just the video platform, and you need to develop your program to support it. But this can be used and implemented in large, in many cities and hospitals that are not using it currently. That's one thing from the telestroke perspective. But going back to your question, Dr. Rivas, really, I think that we're seeing a focus on the outpatient office too. I mean, really, we should be there to support the patients and help them get care and not make it more difficult. And with telemedicine, and there's many clinics now that have highlighted how they've been building their telemedicine systems. And with COVID, insurance companies are paying for it better, are paying for it more, are paying it like in-person visits many times. And that allows the practices to see patients at home, especially follow-ups, lab results, things like that, that the person doesn't necessarily need a full complex neurologic examination. There's many things you can do on the camera, and you can fax scripts or send scripts to the pharmacy, lab orders and things like that. And people can access care from home. It's very hard for many elderly individuals with decreased mobility, especially neurologic patients, to come to the office. And this way you bring the office to them. So I think it's been a good change. Some things have been good from this. I think that hopefully we can build on it and not go back to our usual ways once the crisis ends. We can definitely use this technology much more than what we're using it currently.
There is a question here from, I believe is Tariq Doki. He's saying, with the prothrombosis we are seeing with COVID-19 positive patients, and I know protocols are evolving, in quotation, is alteplase an effective treatment in stroke patients who are COVID positive?
Yeah, no, that's a great question. Infections in general, COVID being one of them, increase the risk of stroke. So we've known this for many years with flu. We've known this with herpes. We've known it with lots of infections. They increase the risk of stroke, and COVID might increase the risk of stroke more. We don't really know for sure. There's lots of people that have mild infections and don't even come to the hospital, right? So there's a larger halo group. We only see the sickest of the sickest. So it's hard to say fully, but there are many people that have thrombotic complications and they don't do well. And part of that is because they're generally sick also. Meaning it's not just that they're getting clots and stroke, they're also getting other complications, end organ damage from the infection. And the stroke is just a manifestation of one organ failing from this severe condition. So those patients don't tend to do well. I agree. We have seen Miami has been a hotspot for COVID infections, and we have seen patients with stroke. Thankfully, we have not been overwhelmed by them. We've seen them, but we don't see them all the time. It's somewhat rare, I should say. And yes, they don't tend to do well. We do give them alteplase, and we do endovascular surgery when they qualify for it. We give them the best chance possible for recovery. But the truth is, most of them don't do well. Yes, I would second that question and opinion.
Fantastic. From Honduras, let me see if I can paraphrase this. In regards to the importance of actually performing an MRI and a CAT scan on ischemic stroke victims, what would be the time frame that you can allocate before you actually say, well, an MRI or a CT scan is not necessarily at this point important?
Yeah, so clinically, especially at the beginning, it can be difficult to tease out whether someone is having ischemic stroke, hemorrhagic stroke, specifically. Subarachnoid hemorrhage tend to have a lot of headache, which is not that severe with the other two, although ICH can cause headache as well, but not usually that very severe thunderclap, 10 out of 10 headache. But by clinical exam alone, you can't confidently tease them apart. So you really need a CT scan to be able to know what it is that you're dealing with. And the interventions are widely different, right? For ischemic stroke, we use antiplatelets and sometimes anticoagulants, or we may use TPA, which would be completely devastating for a hemorrhage patient. So you really need at least the CT to be able to confidently tease them apart. And then MRI is able to identify much better strokes, ischemic strokes, than CT. Then CT, you might not see it. Even MRI, you might not see it. It's not 100%, but it does a much, much better job. And when you see the strokes on the MRI, it can let the clinician know a little bit more as to what might have caused it. If it was caused by just what we call small vessel disease, high blood pressure, hypertension, smoking over time, or maybe it was a clot that came up or some other condition. So MRI helps identify the mechanism, and if you know the mechanism, you can do better prevention. So that is the utility. When you look at epidemiology, if you don't do that many MRIs, your epidemiology is going to be just a little off because you're going to be missing cases or misclassifying them.
And you mentioned one of the biggest challenges is obviously the access to technology,
Absolutely.
especially in countries that are evolving now. And we have changed the way we practice throughout the world in the past 10 years. And yet we see the opportunities to actually capture this kind of conditions at an earlier stage. One of the biggest issues that we have confronted in the past from the public health standpoint is the fact that the cities or towns not close to the actual capital, where perhaps there is access to care, direct access to care and technology, those are the ones that are most challenged with identifying and mobilizing victims that are stroke victims identified already and brought to the city. Um, as a knee-jerk reaction, what will be the first thing that you would teach us in regards to for prevention, especially in areas that are rural or countries that do not have necessarily the means to buy this equipment?
Yeah, so when we talk about prevention, and we're really talking, it's never too late. It's never too late to start prevention, right? So you can always do it at any age. But if you're looking about population public health, you really want to do your prevention early on. So you want to do it when people are in their 30s, 40s, 50s, but 30s, 40s is probably where you want to really try to get people to go to their primary, start checking their cholesterol, start checking their glucose, make sure that they're eating right, they're not smoking, right? The smoking is just one of those low-hanging fruits that we need to be able to tackle in any of its shape, ways, or form. So vaping, electronic, cigars, any of that. And trying to get to those what we call the American Heart Association's Healthy Seven, right? Making sure that obesity is being tackled, making sure that physical inactivity is being tackled, excess tobacco, alcohol, high blood pressure, high cholesterol, screening for diabetes. Those are all things that, especially hypertension is so common, that if you can be able to impact people in their 30s, 40s, you're going to see a lot of benefit when those people reach 70s, 80s. It's never too late to start, though. You should always do it. But I think that's where you want to get access. And then the follow-up is sometimes an issue, right? And especially in rural areas, how do people follow up? How do you get the medications to them? The medications have to be affordable. So systems really have to be designed to facilitate that, which has been a challenge and still is.
Indeed, and I believe that in the future, the change in paradigm has to be crucial in actually focusing on non-communicable diseases and the prevention of those conditions that you mentioned that are currently a major burden for many countries. Dr. Arroyo Barrios from Lima coincides with my comment, and she says, in Lima, there is a lack of information and prevention in the population that live far from the city. The management of support stroke, it would be good to create special program.
Absolutely. I couldn't agree more. I couldn't agree more. And I think that the more vocal people are about this and demand care, that's what drives, public health as well, is what people demand for. I do understand that there's a lot of still communicable diseases, and you can't neglect respiratory infections, number one, killer for Peru. But you can, there's definitely, there has to be a demand for change, and we have to be part of it. But education is a big piece of it, and we call it, I titled this the silent pandemic, and it truly is, because you see it even in the emergency room. It's very easy to ignore a stroke patient. The person is essentially quiet. They don't make much noise. It's not a painful condition. People are not screaming in pain. And they're just, lying there. And you really need someone to advocate for them. And you have to almost flash red lights and everything so that people understand that this is an emergency, that someone is losing their mind, their brain, their most precious asset. And we can do something about it. But because it's just such a silent condition, it's many times ignored. So we see that in the individual patient level, but you definitely see that also at a community public health perspective as well.
Mhm. Dr. De Los Rios, I think that the job that you have is absolutely phenomenal, not only in our system, but because you have been so open to actually assist others, and especially abroad. And you have traveled extensively with us in lecturing and also teaching others how to do this with the means and resources that they have. I want to encourage everybody that is participating today to take advantage of this offer. Send us your questions, send us your concerns, and start exploring ways of actually initiating some kind of a stroke program in your areas. We are in the top of the hour, Dr. De Los Rios. You know how much we enjoy having you and having this conversation for hours on end. And so we have to, as consideration, let everyone go. But before, I want to thank you on behalf of Baptist Health International for the incredible presentation you gave us today.
Thank
To
you,
all
Dr.
of you
Hakeem.
for
My pleasure.
participating, thank you. To all of you for participating and attending. If you have additional questions about Dr. De Los Rios' presentation, please feel free to send them to international@baptisthealth.net. We'll make sure to get them answered for you by Dr. De Los Rios and forward to you in a timely manner. We look forward to seeing you at our next Neuroscience lecture series scheduled for January 20th, 2021. Thank you again. Have a great afternoon and please be safe.